Here we go. All right, so good afternoon, everyone. Glad to see everybody's here. And we're going to go ahead and start. And we're going to start, I'm going to share my screen. And we're going to start right now. I just want to give my one of my professors, colleagues, credit for doing this presentation, putting it together. Just want to give what credit is due. All right, I want to start off with placenta previa and placenta abruption. Okay, so one of my questions to start out in your study materials was, what is painless red bleeding? So if a question was asking you painless red bleeding, what would you put?
Previa.
Previa, placenta previa. So write that down. And what type of delivery do you think this patient will have?
Cesarean.
Cesarean, good, good, good. Okay, very good. Okay, everybody chime in too. Okay, so here the slide shows you the difference between placenta previa and, let me just make sure that I am recording. Yes, okay. I always have to make sure. Okay, this slide here, let me go back to my slide. Here we go, shows you the difference. Now your HESI book has a great little chart too, just to let you know. But placenta previa is painless, bright red bleeding. And her abdomen is soft. Now think about it. If your abdomen is soft and you're bleeding and you have no pain, you always want to think, where's that bleeding come from? Think about it, okay? All right, so that would be previa. Now, when a previa happens, where's the placenta? The placenta is right over. See this os here? Here's your cervix. Is laying right over the os. Okay, so it covers it. So that's why you would have a lot of blood, and it's bright red because it's low down is lower. Okay. Now, when you have an abruption, you have bleeding and it's dark because the abruption, see here up in this picture, this abruption is coming off. The placenta is coming right off that endometrium. Okay, so the blood is higher up. So by the time it gets down and comes out of the cervix, is dark red. Now, you're having all this, when something abrupts, is pulling apart, is it not? It pulls apart. So when it pulls apart, it's going to cause pain. It is very painful. And she has pain in her tummy, her abdomen, and her back, because that thing is coming right off that endometrium. And when you examine this lady, her abdomen is rigid and board-like. So that's the second question. What condition is the patient in if she's having a rigid and board-like uterus? That would be placenta abruption. Now, what type of delivery do you do for this kind of patient, guys? What kind of delivery?
A C-section.
Yeah, C-section, sure. You could never deliver vaginally. This is a medical emergency. Okay, in obstetrics, when somebody comes in and I'm palpating her abdomen and I find it's rigid and board-like, and then usually I have her on the monitor, the fetal monitor, and I have decelerations. I gotta get that baby out. If I don't, what's gonna happen? Baby can die, and moms too. Now, what causes the placenta to abrupt? You're probably asking yourself. Well, some trauma. A blow to the abdomen. Mom takes a hard fall. She falls down. Maybe she's in a car accident. That's why whenever a woman who's pregnant is in a car accident, what do? We send them to the hospital. And I've had a lot of ladies say, oh, no, I'm feeling fine. We put her on the monitor and we find that fetal heart rate is low. Okay. All right, here we go. All right. So another thing too you have to be thinking about is culture, and you have something, some part of your in the beginning of your chapters goes over culture. I want you to know why it's important to have the knowledge of different cultures because it can influence labor. Okay, so you want to be flexible, and I want to include the family and staff in the care, and very and active, and you do therapeutic what? Listening, right? Okay. And I've had patients where, you know, they said, could we have, she was a Native American, and she says, could we have my family come in? And the family was a tribe. But I was okay with that. Why was I okay with it? Because that was her culture. Did it make her feel better? Do you think it made her feel better? Yeah, it was great, because those influences influence her. And remember, one of the 5 P's of the labor and birth process is psych. And this is what it does. It helps her feel better, and she can handle labor better. She feels that strength from her family. All righty, moving right along. Remember, this is a review, so things are going to be moving quite fast. It's called preterm labor. Now, what is preterm labor? Well, preterm labor is from 20 weeks up to 36 weeks and 6 days. Okay, 20 weeks. Now, 20 weeks is the time of what? Viability. All right, so 20 weeks and 0 days.
Stopped.
Hold on just a moment. Okay, it's recording. Hold on. Okay. I heard it was recording stopped, so I want to make sure I still was going. I'm still going. I'm still recording. Okay, so it's 36 weeks and 6 days is preterm. When she turns over that next day, she becomes 37. She becomes term. Okay, so what happens in preterm is that the body goes into labor. So you start having contractions. Remember, contractions is the power, one of the other P's of the labor and birth process. And so with the contractions, they dilate the cervix. They dilate the cervix. So she has cramping or contractions. She's got maybe some leakage of fluid. She has lightning. She has what? What's lightning? Where the baby drops down, backache, pelvic pressure. So what are we going to do? Well, we're going to give her some medications. The one that we use a lot is magnesium sulfate. Magnesium is used for preterm labor and for what? Preeclampsia. Okay. We're going to maybe give her some butylene. Now, I'll tell you, these medications do have an effect on the heart rate. Write this down. Butylene increases heart rate. You need to know that. Okay, when I say you need to know that, what does that mean? You might see it again. Okay, and then you have antibiotics. Sometimes they go into preterm labor because there's an infection in the uterus. Now, if I'm going to deliver a preterm baby, once a woman gets past 2 centimeters, it's very hard to stop their labor. I'm just let you know. So I have a patient that maybe now she's 2, but she's completely effaced, and this baby has come down to a 0 station. Okay, that's going to be pretty hard to stop. So what can I give her that would help this baby when he's born? Well, that would be betamethasone. Betamethasone is given in 2 doses, 12 milligrams, 24 hours apart. And what it does, betamethasone is a steroid. And a steroid, you know the functions of a steroid is to what? To enhance. So if I give betamethasone, I'm enhancing the production of surfactant in the baby's lungs. Surfactant. You'll need that for exam number 3. All right, so betamethasone is given. Magnesium sulfate, as I said too, we give that a lot for what? Preterm. Now, all these medications that you see on the side, indomethacin and epinephrine and magnesium sulfate and terbutaline, they're all under the classification called a tocolytic. Those are uterine relaxants. That means they relax the uterus, okay? So that's why it's called a tocolytic, because the word toco is actually comes from, we use this, it means uterine, the uterus. So what it does is when we do like the fetal monitor and we put the toco diameter on mom to pick up contractions. So that's toco. Okay. And then again, we have her on activity restriction or bed rest. There's no doubt about it. Okay. Then on the other hand, I go from preterm, I go to prolonged pregnancy. All right, so a prolonged pregnancy is a pregnancy that goes for 41 weeks, and 6 days. So what's my risk on having a pregnancy to go so far? Is that, well, you have a placenta. Remember, the placenta is a temporary endocrine organ. It's also a temporary respiratory organ. And so it gets old because the body knows this placenta should last about 40 weeks. When you start getting into 41, 42 weeks, everything starts to get old. The baby gets big. There's no doubt about it. Meconium, it gives a higher risk of this baby now having his first bowel movement in the uterus. And that's called meconium aspiration. Also, the water, we have now decreased fluid. So we have a condition called oleohydramnios, decreased amniotic fluid. Now we know when the decreased amniotic fluid, it can have a result on what? The cord, the umbilical cord. So then, because we don't have this buoyancy inside the uterus, the cord is what? Compressed. When the cord gets compressed, the heart rate of the baby goes down. And those are what are called variables. Remember variables? Well, it goes down and comes back up. A prolonged pregnancy puts the mom at more risk for a hemorrhage because the uterus now is getting over distended because the baby's getting big. So it puts mom at more risk after delivery for a hemorrhage. She has more risk for a peritoneal trauma, such as a laceration, because the baby is getting big. And so now we put at more risk that she probably would need an episiotomy. Okay. And then of course you have an increased risk of cesarean. And maybe she goes, we do an induction of labor for this patient and she doesn't progress. So we have dysfunctional labor where, you know, she gets to 4 centimeters and then she's like, she stopped. Then we would have to augment with her maybe, or we're doing an induction. So we got Pitocin going, but she's not progressing. They end up doing a C-section because mom gets tired. When you're having contractions every 2 to 3 minutes and they're lasting 60 to maybe 90 seconds in duration, that's a good labor pattern. And she's not making good progress. That's tiring, very, very tiring. And then of course you have this too, where maybe her dates, maybe she was off a little bit on her dates. That can happen. But in today's world with our ultrasounds, especially that first ultrasound that's done when they first come in on the first initial visit, we do really a crown rump measurement. And that really gives us a good idea of when they're due. So we don't see that as much. And then of course, because they got to be 41 weeks, everything gets old, like I said, we have to monitor them. So they have to come in to your clinic for like an NST, a non-stress test, because we want to know the baby's okay. We have to know that, okay, everything, he's still handling everything well. He's still getting oxygenated from the placenta through the cord. He's doing okay. And then of course, we have induction of labor. Write that down for C-section, induction of labor. Okay. Alrighty. So now we've gone from preterm labor to prolonged labor. Now I'm going to take you through precipitous labor. You're probably saying there's a lot of different labors. Yeah, and they all have their different consequences. So precipitous, what does that mean? Quick. The onset to the time of delivery is less than 3 hours. Now you may say, well, that's good. But in order to get that, she's having what we call hypertonic contractions. So these contractions, guys, are they're up and down, up and down, up and down. They're not the nice little hills that you normally have with a contraction. These are up and down, up and down. It's called hyperstimulation, or another term is called uterine tachysystole. Now, what risk is this to mom? Well, there are some risks. Mom can hemorrhage because the uterus has been contracting one after the other. Firing one after the other, okay? And so by the time that she delivers this baby, the uterus says, okay, I'm tired. That's it. I'm not contracting it. She runs out of her own oxytocin. That's it. We're done. So she's set up for more of a hemorrhage. She's also set up for placenta fragments, retaining them. So that could remember this, retained placenta fragments can cause a hemorrhage. She's at risk for uterine rupture because, again, those contractions we were talking about, they're one after the other. That can make the uterus rupture because it shouldn't be. We don't want uterine hyperstimulation. No, we don't, not at all. And then a risk for peritoneal trauma, or even worse, you got a hematoma in the vagina, and that's very, very painful, very painful. Hematoma is a collection of blood. And when you have that in the side wall of, say, the vagina, it causes pain. I'm going to tell you honestly, from my own my experiences working with lots of women that have hematomas after a fast delivery, even Percocet, oxycodone, the pain medication, didn't even touch it. And then the baby, on the other hand, he can have intracranial pressure. He can have even a bleed, intracranial hemorrhage, and all that would lead to hypoxia. So is precipitous labor good? What do you think? Ms. Hudson, what do you think? Is a precipitous labor good?
It doesn't sound good.
No, it doesn't, does it? No. But most people say, oh, she had the baby so fast. She had him in the car, or she had him in the elevator. Well, that's all good, but all these things could happen, right? It's kind of scary to see all that happen. Okay, let's go on. So now we go into the term induction or augmentation of labor. All right, so what's the word induction mean? It means to what? Induce, start, right? Okay, so what it is we're going to start her. For some reason, her body didn't start secreting oxytocin. So she didn't go into labor. All right, going into labor is a natural process. So we have someone that we're going to have to give Pitocin to. And Pitocin is a medication. Write that down because that's a pretty important medication in maternity. And it's very, very strong. And we give it in milliunits. So we're going to start the initiation of labor. And so we're going to have her on the monitor. We always have to monitor the fetal heart rate. So we're going to give her the Pitocin. Where augmentation of labor, augment means to what? Add to. So what happened is that she was in labor. Her body went into spontaneous labor, okay? But what happened to the contractions? They dwindled out, okay? And so now she needs some help. So now we're going to give her Pitocin. So now we're going to augment the labor. You see the difference? Yeah? Okay. So You got induction and augmentational labor? You got them, Ms. Hudson? You doing good? Oh, okay, all right. All right, because these are very important terms for you to know. So this could be an all but apply question. All right. What are the indications for induction of labor? All right, and you've got to pick them out. So we're going to go over them. If you have a patient who has hypertension, gestational hypertension, if you have ruptured membranes without spontaneous onset of labor, yeah, you got to get the baby out. Remember, from the time she ruptures, you have to deliver this baby within 24 hours. Infection within the uterus. Time to gotta get that baby out. Mom and baby get sick. Medical problems in the woman that worsen during pregnancy. Yeah, if a woman has lupus or she has any other problems, I'm gonna have to deliver her. Yeah, we gotta get the baby out. Fetal problems. Maybe you have an IUGR baby. That's an intrauterine growth restricted baby. Okay, gotta get the baby out because then the baby is not in a good environment for growth. It's in what we call a hostile environment. That means that the baby is not getting the oxygen and nutrients that it needs to grow. Or you may have a lady that is prolonged pregnancy, like we talked about. She got 41, 42 weeks, and she's not going into spontaneous labor on her own. She's going to get induction of labor. Okay. And then you might have fetal death that you're going to have to do an induction of labor to. A baby that passed away in utero, we're going to go ahead and get the baby out. So we want to do it. We do inductions, but we don't do them too early. We want to avoid before 39 weeks. Years ago, I'm going to tell you, we used to do a lot of inductions, but now the research has shown that the brain is still developing all the way through to beyond 40 weeks and beyond. So we don't try to do those inductions too early. Oh, they used to schedule inductions maybe on the grandmother's birthday or mom's birthday. And so, no, we don't do that anymore. Okay. Now, on the other hand, you have a category called contraindications to induction. Contraindication means we cannot do an induction. This could be an all that apply question. Pretty good too. So if you have a placenta previa, like we talked about, you never induce labor because why? You would cause her to hemorrhage. If you have an umbilical cord prolapse, you can never induce because the cord is coming through the cervix. And if you have a contractions, that's going to cut off the oxygen to the baby, you can kill the baby. If you have a breech or a transverse lie, you cannot do an induction. You would never want to do an induction on a breech because a breech and a transverse lie will be sectioned. You got a transverse lie, if you think about it, it's laying horizontal in the uterus, and what's coming through a lot of times I see it, it's like a hand, or you can feel the shoulder, and so you would never want to put that baby in an induction. Remember, what an induction is, I'm making her have contractions. All right, and then the baby's head is high. If she's above, remember the pelvis, and zero station is at the ischial spine. And if the baby is high, like a -2 station or -3, that's real high. You don't want to do an induction because why? Cord could be prolapsing. You don't want to do it on a small maternal pelvis either. If you have a platytoid pelvis or an anthropoid pelvis, those are really, hard pelvises to get a fetal head through. Active herpes infection. No, we don't want that baby to come through the vagina. She'd end up with a C-section. Abnormal size or structure of the mom's pelvis. We just talked about that. And a previous classical cesarean incision. Can never do an induction. write this down. You can never give Pitocin to a VBAC. A VBAC is a vaginal birth after cesarean. You don't ever give Pitocin because you can rupture their uterus. Now, if they have a bikini incision, and they have it on their uterus, and then you cannot induce them. They can go into labor, but you cannot give Pitocin. You can never induce a previous cesarean. Okay. And then, of course, prematurity is not good because the baby can't tolerate those kind of induction. Okay. Instead of a preemie, I want to stop that premature. I wouldn't want that baby to come out, but I wouldn't do an induction. All righty. So we're going to move right into false versus true labor. Now, let me just tell you something. The easiest way to remember this is in true labor, you're going to have cervical changes. Write that down. True labor, you're going to have cervical changes. So you're going to have cervical effacement and cervical dilation. Okay. So something's going to happen. Those contractions, those powers have been strong enough to dilate that cervix. Okay, so that's true labor. Okay, but let me just let you know, we have patients that come in to the triage. And so it's my job to, put on the monitor, take mom's vital signs, make sure baby's okay. And now I'm going to observe her. And she may be like 2 centimeters, 80% efface, and may a -1 station. All right, and she could be contracting every, say, 5 minutes apart, 5, 7, kind of irregular contractions, but not, but they're coming every 5 to 7. Okay, so I look at her and she's like, oh, I know I'm in labor. Okay, but I've got to observe you for a while. So what I'm going to do is I'm going to send you out walking. So I send my patient out walking, and she comes back in 30 minutes. I check her FHTs again, fetal heart tones. Everything is good, within normal. So what do? I send her back out walking. So now I've had her walking for an hour. She comes back, she tells me my contractions are, they're much quicker. They're coming really, really soon, nurse. Good. And I do a vag exam, and guess what? She's dilated now to 3 centimeters, completely effaced, and the head's at a 0 station. Is she in true labor? Yes, she is. See? So that's what we do. Versus false labor, there is no change. Okay. So we're going to discharge her because there's no change in the cervix. They get very disappointed. I'll be honest with you. Oh yeah, lots of disappointments, but that's okay. Okay. I just usually very positive. You're always positive in maternity. And we say, that's okay. Go home for a little bit. Go home and take a shower, relax, put your feet up. Some even go to sleep for a while, and then they get up, and then they come back to the hospital, and now they're in true labor. So that's what it's all about. Okay, hello, Mr. Patrick. So let me go on. Patrick, who's your professor? Hi, who's your professor?
Oh, Professor Jesse.
Okay, good. Let me just write you down so I have you. Okay. We've gone over some things already, Patrick.
Okay.
All right, good to have you. All right, let's go on, guys. So here we have the stages of labor. Now let me give you a few hints. You will see the stages of labor next week on your test. Okay. Now, how you want to study these is you have to know what's in each stage. So like the first stage. Now, in your book, it has a little different in the dilation. I'm going to be honest with you. So I'm going to give you those dilation, but that's not as important as what goes on in each stage, each phase. Now, the first stage of labor has 3 phases. So write down first stage of labor, the 3 phases. The first phase is called the latent phase, Latent, latent. It's also called early. All right. She's usually dilated from 0 to 3 centimeters. Okay. And during that time, she's like, oh, hello, nurse. How you doing? She's kind of cordial. You know, she's this is the time that you basically get your consent form signed and you orientate her to like the room and things like that. She's kind of happy. She's happy to be here. And then she has a contraction, then she has to breathe, and then she relaxes again. Now, when and during the latent phase, you use non-pharmacological means of pain relief, non-pharmacological. That means, you know, diversion, distraction, hydrotherapy, getting in the shower. I used to get in the shower all the time with my patients, and it relaxed them. Some of the labor delivery units have whirlpools. Oh yeah, those are good. Get in the chair and rock. Rocking is good. Now, another good non-pharmacological means of pain control is called effleurage. Write that down, effleurage. Effleurage is where it falls under skin stimulation, where she's massaging her belly. And just her sitting there in the rocker. Now imagine, y'all rub your belly and do a little rocking. Don't you feel relaxed? Okay, so that will relax her. Now, she's laboring. She's got some good contractions now. She's every 3 to 4 minutes. She's getting active, guys. So the active phase. So you go from 4 to 7 centimeters. This is in the active labor phase is a good time to get an epidural. This is when you get the epidural. She made it through the first few dilation through centimeters. Now the contractions are getting harder. Okay. And she's not smiling face like this little girl over here, this little cartoon face. She's now what? Here she is. She's more serious, okay? Because the baby's starting to descend and put some pelvic pressure. And that makes that's a good thing, because that helps make the cervix, dilate more and much more efficient. It's wonderful. But she feels it. She feels that pain. So now, as I said, it's a good time to get an epidural. Okay, she's earned it. So you're going to get her to have an epidural. Then from there, she goes in transition. Now, transition is, this is her in here in transition. She's like, oh, you have to really work with every contraction and breathe with the contractions. Now, this is when, if she doesn't have an epidural, she might feel the urge to push. So I don't want her to push. You don't push before you're 10 centimeters, because the cervix, what it is now it can tear. If you still got cervix around and she's pushing, the baby's head is putting this pressure against it, what happens is that the cervix can get thicker. And so that's not good. So we don't want her to push. Now write this down. Remember this, okay? I'm giving you a hint. You want her to blow out the birthday candle. I used to tell my patients, see my finger? That's a birthday candle. Now puff your cheeks, blow out, and puff those cheeks really good, really good. And try to push down. You can't do it. So that's how I kept my patients from pushing before they got 10 centimeters. Okay. So then we go from the first stage, we're pushing. Now pushing, I'm going to tell you, goes from anywhere from 0 to 2 hours. We don't like to push greater than 2 hours, because why? Because she gets really tired. And then they end up needing like forceps or vacuum assistance. And we'll get into that in a few minutes. So I'm going to go ahead and and just have a push. And this is when I usually have like an LPN with me and on myself RN, and we're holding the lady's legs and we're encouraging her to push. Now, she pushes really efficiently. Oh, great. So now we're going into the second stage. Write this down. Second stage is pushing, and now we're going to expel the baby. Okay, our baby is born. Yay. Okay, so baby gets born. That's the second stage. Now, baby's out. What do I have left up in the uterus? I have the placenta. So the placenta now has its own stage. That's how important the placenta is. And that's the third stage, delivery of the placenta. So now the placenta comes out, and we never pull on the placenta. No, no, no. Because when you try to rush this, the placenta has to break away from the endometrium. And when it breaks away, okay, it causes like a little area here that's like an open cut. So we don't want to pull this placenta, because sometimes the fragments, pieces of the placenta is stuck to that wall of the uterus. And so then she can have what? Retained placenta fragments. That's not good. No. So we wait for the placenta to come. Usually it comes within 30 minutes. And we can have the baby to breast during that time, and that would increase the oxytocin release, and that would give us more contractions, because we can't give her more pitocin. We can't give her something to contract until the placenta is out. Okay, so now the placenta comes out. Okay, and so the LPN that was helping me at delivery, she's looking at the placenta, and we have two sides of the placenta. Remember, we have mom's side, which is called the what? The Duncan. Okay, and then we have the neonatal side, which is called the Schultz. Now I'm going to tell you how I learned it, and I tell you what, it stuck with me for over 45 years. Okay, the shiny side is neonate, it's the new. It's called shiny Schultz because it looks really shiny, new. Anything shiny is pretty new, right? Okay, the mommy side, which was adhered to the endometrium of the uterus, it has all these kind of lobes to it. It's kind of dirty looking, and we call that the dirty Duncan. So I just thought maybe you like to remember that. Okay. We have to make sure the placenta comes out intact, because if we don't, she can hemorrhage. And hemorrhage is never good. That's how many women probably, if you think about it, you go back in history and obstetrics, a lot of women died after childbirth. And I think it has to do with they didn't deliver the placenta. When they did, they pulled on it, and they didn't realize that they should not have done it. They didn't know any better. So she kept bleeding until she hemorrhaged. All right. And then we go into the fourth stage. That's your recovery. So it's like 1 to 2 hours afterwards, and it lasts how long it lasts, about 1 to 2 hours. Now, recovery is necessary because I have to make sure that the fundus of the uterus is firm. Okay, because if we don't have a firm uterus, she will hemorrhage, she will bleed out. So when I have a patient and I'm now recovering her, I have my IV bag going. I have pitocin 20 units in that IV bag. It's infusing. So that's helping that keep that uterus firm. I'm checking for the fundus, which is the top portion of the uterus. I'm making sure that's nice and firm. Okay, I'm taking her vital signs. I got the blood pressure cuff on, the pulse oximeter on. I got a temperature. Okay, I'm having baby to her breast. I'm encouraging breastfeeding because that helps with giving again her own oxytocin from the anterior pituitary. I'm getting that stimulated. So I'm getting even more contractions. And a lot of times women will complain to you. They say the afterbirth pains are worse than labor. I thought I was done with labor when I delivered the baby. Not yet. We want to make sure that she stays nice and firm. Now, another important thing I want to say in here is about the bladder. The bladder lies right underneath the uterus, does it not? Okay, going back to your anatomy and physiology. So you got the bladder, say here. This is the bladder, and the uterus is here. Now the bladder, when the bladder gets full, right? It gets full, it's pushing the uterus what? Up, right? And it pushes that uterus up and over to the side. You see how that goes? Okay, over to the side. So she may still be kind of firm, but she's this we call displaced. It's a displaced uterus. So what am I going to do? I'm going to empty the bladder. When I empty the bladder, see now, watch, empty the bladder gets what? Flattened. Where it happens to my uterus? My uterus comes over and back to midline, and it comes back down to the level of the umbilicus, her belly button. That's where the uterus should be. So write that down. The uterus should be at the level of her belly button and midline. That's where it should be. If it's deviated over to the side, then check the bladder. And you can palpate. You can palpate a bladder, and you can feel a bladder that is full of urine. Okay. All righty. So that's what's important. And I know you'll probably see that concept. You'll see that one again. Okay. All righty. Everybody, we're moving right along, because don't forget this is a review. So now I'm going to discuss contractions. We said before, contractions are one of the P's of the labor and birth process. It's called the power. It's called the powerhouse. Okay, you have to have contractions. Unfortunately, you do in order for the cervix to dilate in the face. And I tell you what, they're painful. So I mean, they're really, really painful, and they increase, you know, from the beginning to the end. In the beginning of labor, when she's only about maybe 1 centimeter, you know, they can be, the frequency can be maybe 4 to 5 minutes apart. Okay, that's how often they're coming, frequency. When she gets into the active phase, okay, of labor, then contractions now are closer together. They're like 2 to 3 minutes apart. Okay, and they last 60 seconds in duration. Okay, and they're powerful. And then she gets in transition phase. Now she's quite dilated, and now she feels pressure from the baby head descending. The contractions are closer together, and they're strong. They palpate. When you palpate using 2 fingers on the fundus of her uterus, they palpate firm. So they can start out mild. As she progresses, goes to moderate, and at the end it gets really firm and often, quite often. Okay, has to be. That's how the progression of labor is. So here's a good little drawing, and I know it comes right out of your book. And this is what a contraction looks like. So when you go up the little hill, it's called increment. Just think of the word increase. Okay, I'm increasing. I'm going up the hill. All right. So when I go up the hill, what kind of breathing do you think I would have in here? I'm going to do slow chest. I want to prevent her from hyperventilating. So I'm going to do slow chest. So like it goes like this, in and out, in and out, just really slow and easy. Okay. And as the contractions get a little stronger, here's the peak of the contraction. Now, Hesse uses that word acme, A-C-M-E. It's the same thing as peak. It's an old term. And that just means it's the strongest. Just like when you climb a mountain, right? You're going up the mountain, you get to the top. That's the strongest part, right? Right. You feel good too when you get up there. And then you got the peak. And then when you're at the peak, what type of breathing? Well, in order to handle those really tough contractions, the strongest you're going to have, I'm going to revert to a little quicker breathing. And it sounds like this. And then as soon as I can, I decrease her. I'm coaching her, and I'm here it comes down. This is called the decrement. It decreases. So as soon as she comes down off that mountain, I'm going to do the slow chest breathing again. In and blow it away. In and blow it away. And just let her calm down off this contraction and then come here. And this is called the relaxing time. It's just the interval between one contraction to the next. It's called a resting tone. All right. And then she's resting here, and then she has to get going again. And this is what, the electronic fetal monitoring is really good to show when the next contraction's coming. So whoever's in the room with her can actually see this. And I do teach the husband in the room or her partner. When you see this line starting to go up, that means she's going into another contraction. So you can help her start breathing. And again, increment, slow chest, acme of the peak would be a little faster. And then as you come down, the decrement, I slow down again. And the reason why I do that is so she doesn't hyperventilate. Because when your patient hyperventilates, they get tingling right around their mouth and dizzy. It's a weird sensation. It's scary. I don't want to scare her. We're in labor. So we're going to take her hand and put it over the nose and mouth and just breathe, breathe. And it will subside. If in her little childbirth preparation bag, she has a nice paper bag, she can put a paper bag over her nose and her mouth, same thing. Okay, so now we talked about the phases here. Now, I want you to know frequency. That means how often the contractions are coming. When I say like they're coming every 2 to 3 minutes, that's frequency. Duration is how long the contraction is lasting. Now, heads up, write duration down. Okay, is how long is lasting. So it starts in the beginning of this contraction, and their duration goes all the way to the end of this contraction. All right. So again, is the beginning of this contraction, just one contraction, to the end of that one contraction. Okay, that's duration. So it's telling me how long is actually lasting. And remember I said a good contraction pattern is the contractions last 60 to 90 seconds in duration. I don't want them any longer than 90, no. And 60 is good. The babies, when a mom has a contraction, the I'm watching the baby's heart rate, because babies actually have to hold their breath during a contraction. Because when you have a contraction, it compresses everything. That cord where it's carrying all the oxygen is compressed. So he kind of like, mom has a contraction, baby, this is what baby does. And whatever residual he has, I hope I made you laugh. Whatever residual he has keeps him breathing, okay? But that's why you don't want these contractions to last a long time, because baby doesn't like it. His heart rate will go down if mom has these hyperstimulating contractions. Okay, so we went over frequency and duration and the breathing pattern that happens during a contraction. Okay, all righty. And all this, guys, all this, and I know I have some men here, all this a woman needs to go through in order to what? Open up that cervix. She open up the cervix, efface the cervix, and dilate. All right. That's why whoever's in the room with the woman as being the support person, you just do whatever. You rub her back, you rub her shoulders, and you keep her really relaxed, okay? And if she says, I want water, I want ice chips, are you going to feed her ice chips? Yes. Okay. Okay. So now we're going to talk about our little guy inside. Okay. Fetal heart rate patterns. Okay. Know the norm. The normal fetal heart rate is from 110 to 160. Anything below 110 would be considered bradycardia, fetal bradycardia. Anything greater than 160 is called fetal tachycardia. Okay. So I want that fetal heart rate to be in that range. All right. The variability, when we talk about variability, is like little squiggly lines on the monitor. And what it is actually the beat to beat of his little heart rate. So if he has, from beat to beat, he has 5 beats or less, that's not good. That's called minimal. He's just barely hanging in there. We don't want that. I want to have moderate. I want to have where I have some 6 to 25 beats per minute. Again, it's beat to beat. So it'll be those little squiggly lines. Okay. Now, if I have marked variability, that means I got a lot. I have greater than 25 beats per minute. So those lines would be, if it's greater than 25, it's like, it looks really like erratic. You know what I mean? And so do I want that? No. I see those kind of fetal heart rate tracings when I have a patient that just had cocaine and then she comes to the hospital. The fetal heart rate would be like 180 and it would have all this marked variability. It's just all over the place. And then baby crashes. Then the baby crashes. So it's very difficult to see that, but that's what happens. So that's variability. And if you look in your book, HESI has really good strips and you can see the variability. And the variability is also those squiggly lines. Okay. Accelerations, I mean, accelerations are A-okay. All right. Remember veal chop? Okay. So accelerations, I mean, my baby is doing good. And when I say my baby's doing good, I mean the baby is well oxygenated. You know, he's getting all the oxygen he needs. He says, hey, I'm in here. No problem, nurse. Keep it going. And then I have a deceleration. Now, decelerations, they tell a little story. If you have a deceleration with the acme of the contraction, let me go back to that contraction. It'd be easier to explain this. So I'm going back to my contraction. So if I have a heart rate that is up here by 120, see my little arrow? Okay, and then I have a deceleration. Everybody see the arrow? Just give me a thumbs up. Okay, thanks. And then you have a deceleration. So I had a baseline of 120, I have a decel down to 90, okay? And then it's with the acme of the peak of the contraction. That's called head compression, head compression. That means the baby's head is descending. That's good. So say she's 8 centimeters, all right? And all of a sudden now on the monitor, I see the head, the heart rate go down with the acme of the contraction. And then it comes back up and she's back and baby's back up to 120. That was an early deceleration. That's okay. That means the head's coming down. If you were coming down the pelvis or you did one day when you were, just before you were born, the head gets molded. Okay, so it gets kind of squished, the pelvis. So if you have pressure in your head, what happens? The heart rate goes down. Okay, so that's what happened. So that's, I can handle those because I know it's only going to last a little time. So what am I going to do? My interventions? Well, I'm going to flip her over to her side. I'll do the lion of the left lateral. I like the left lateral because it gives more blood perfusion to the uterus. So it's the choice. All right. So now the next deceleration I want to talk about, they're called late decelerations. Now I have a cartoon that I usually give out, and it says it's good to be early for dinner, but never be late for dinner. Right? Otherwise you get in trouble, right? So in class, you can equate this, everybody. It's good to be early for class, but it's never good to be late for class, right? Okay, so lates are not good. Lates are caused by the connection, the relationship between the uterus and the placenta. when a baby gets to be like 40 weeks, 41 weeks, 42 weeks, remember the placenta starts to age. And so it's not perfusing like it needs to. And so what happens is that there's a diminish of oxygen flow between the uterus and the placenta. So when that happens, the baby has the problem because he says, I need my oxygen. So what happens is his heart rate, so you had a heart rate, say, of 120, and he's going right along, and then mom has a contraction, and then you notice that you have a deceleration of the fetal heart rate. Decel. It starts after the contraction. So write that down. Late decelerations start after the contraction. And so now you have this late. And it's lates are not never good. So what am I going to do? Well, I'm going to follow that mnemonic I told you called LION. So write down LION. You're going to put her on the left side. She'll have an IV, 1 IV fluids. You're going to give her oxygen, 8 to 10 liters by face mask. And then I have to call for help. I have to call the doctor. Hey, I need some help in here. Call Dr. Boone. Let's get some help. We're having late decelerations. Because I tell you why, when the baby starts having late decelerations, he's starting to get into trouble. And I don't want to get into trouble. I don't want to lose variability. Okay. And then I have variables. That's another decel. And we know variables are caused by cord compression. Like, you know, they're in there and they're playing around and they can grab onto their cord. And all of a sudden you see this variable. It's like a shape of a V. And they're variable because they change. They don't occur at any certain time. They can occur before a contraction, after contraction, they just occur. And they're in the shape of a V, a W, or a U. And how you remember it is a sudden drop and a sudden recovery. So that's why it's a shape of a V, because a V, it doesn't a V drop and go back up, right? That's a V. So variable drops and then it goes back up quick. It's a sudden drop and a sudden recovery. Sudden drop, sudden recovery. And that's because it's caused by cord compression. Now, cord compression could be baby's holding onto his cord, he compresses himself. Or she could have oleohydramnios, which is a decrease in amniotic fluid. And when you have a decrease in amniotic fluid, the cord can compress. All right, so those are your decelerations. Okay, and here's that old saying, veal chop. I think you probably had it in class, but it's a good way. You write down VEAL on one side and write CHOP on the other side. And V stands for variable deceleration caused by cord compression. The E stands for early decelerations caused by head compression. Yeah, the head's coming down. A is for accelerations, and it's A for A-OK. Hey, I'm okay in here, nurse. I love accelerations. Late decelerations is caused by uterine placenta insufficiency. All righty. I know that's a lot, but if you write down that term, the mnemonic field chop, it really does help. Okay, so this is your management, say, of an abnormal fetal heart tone. I already discussed LION with you, so that's what it looks like, LION. And the L is for left lateral, as I already discussed that. I is for increased IV fluids. O is for oxygen at 8 to 10 liters via face mask. We don't use nasal cannula in maternity because it doesn't deliver enough oxygen. And then N is for notify the physician. Hey, I need help in here. Okay. Now the other mnemonic is for when you have a fetal heart tone and you're in the room, and maybe if you're given Pitocin, you always want to stop Pitocin. Pitocin is a very strong drug which makes a woman contract. If you're having abnormal fetal heart rate pattern, you do not want to be giving her Pitocin. No, babies can't tolerate it. You're going to have your position change. You have your oxygen going. You have your IV fluids. And sometimes too, because if you have what we call hyperstimulation of the uterus, that means contractions are coming way too soon. There's no resting tone in there. I may have to use a tocolytic. So the tocolytic I would probably use here would be terbutaline. Remember, write this down. Terbutaline increases heart rate. Write that down, everybody. You'll see that again. All righty. All righty. So here we got some non-pharmacological pain relief measures. Remember, this is really, I know Hesse likes this, and I know you're going to see this again. So I would really, know these. You want to always promote relaxation, non-pharmacological. You have your touch relaxation, touch. You have effleurage. I talked about this already, effleurage. You do a circular massage with your fingertips. And this is what the woman can do. She does it herself. She sits there in a chair and she does it. A nice massage by her significant other in the room. Sacral pressure, counter pressure. Look at my hand. See here? This goes right on her sacrum, the palm of my hand. And we do counter pressure. And the reason for that is maybe the baby in early labor is in a OP position. That means the baby's head is sticking up, its chin is up. That's called occipital posterior. That causes a lot of back labor, folks, a lot of back labor. And that's where the sacral counter pressure comes in, is that, her significant other puts his hand or her hand against her back and gets some good counter pressure when she has a contraction. It works. It really works. And another good one is I used to do is get my bedside table in the room. I put a pillow on it. I have the woman stretch her back, stretch over the pillow, and that stretched her whole back out. And then the husband, he put his hand on her low back and massage. Oh, it worked like a charm. Especially if you're in early labor and the baby's in OP position. Then we have thermoregulation. These are, again, non-pharmacological pain relief measures, positioning. How about diversion and distraction? Yeah. How about hydrotherapy? That's one of my favorites. I can tell you something. I put my patient in the shower one time, or many times, and she just relaxed. Oh my gosh, she was in there. She's like, I said, okay, she's in there for a while. I said, okay, Miss Jones, time to come out. She's like, I don't want to come out. And all of a sudden I see down her leg, she's got some bloody show coming down. Bloody show is good. Bloody show, now write this down, because I know you're going to see it again. Bloody show is blood with mucus. Okay, so she'd be in there on the shower, and so here comes down her leg some bloody show. Yes. Why am I excited about bloody show? Because that means the cervix is opening up, and the cervix, so she's dilating, or she's effacing, and now all that has a little blood to it, because the vascular cervix is a very vascular area. Sure, it's wonderful. I go, yes, we're making progress. That's why I'm happy. All right, so those are non-pharmacological. All right, we kind of went over the breathing already, but just want to go again, make sure you got this down pat, because you might see this again. All right, so hyperventilation, we always want to avoid, okay? Because I told you, numbness, tingling of the extremities, especially around the mouth. I've seen a lot of that. Lightheaded, usually when they say, gee, I'm feeling funny, nurse. And I've been trying to coach her breathing, and she's been breathing a lot fast. I said, let's go ahead and treat you for some hyperventilation. I want to get a hold of that before it goes into any further. All right. And then again, if we oxygenate for mom, we're oxygenating for baby. All right. That's why we use a face mask, because nasal cannula cannot give the oxygen we need in a short amount of time. Now, this here, you will see again. Write this down. It's called a doula. D-O-U-L-A. When I say you're going to see it again, you might see it next week. All right. So a doula. So what is a doula? Well, doula is a support person, and it doesn't have to be medical. And they go through a class is to provide physical, emotional support. I'm a doula. A lot of retired L&D nurses become doulas because we know the labor process, and so we can help our patient. So we're giving a lot of emotional support. And then we coach them through breathing and pain. And because they know us, and because we meet with them several times before they go into labor, they're familiar. We go over the different breathing and how we're gonna breathe through the contractions. So it's kind of nice. Doulas are nice, okay? And doulas work alongside the L&D nurse. L&D nurse is the medical person in the room. The doulas are not medical. Okay, all right. Then you have, let's see, some narcotics, because she's in pain, and it's really tough pain. So you can give Nubang or Stadol. Now, when we do that, we give small amount, because remember, anything we give mom crosses the placenta and goes right to baby. And when it goes to baby, it can cause respiratory distress in the infant. So when do we give that? Well, the best time to give that maybe is when she's about 3 centimeters, 2 to 3, where she's having a tough time, okay? And then you can kind of gauge, if you're giving Nubang or Stadol during that time, I can guarantee she's going to ask for an epidural as we get into the more active phase and she dilates more. Okay, so those are kind of judgment calls we have to be very careful about. The one thing is, you don't want to give a narcotic to mom when she is in transition. Write that down. You don't give a narcotic during transition, because again, what happens? You give her a narcotic and it goes to baby. So if she's in transition, she's going to be going into the second stage of labor pretty quick, okay? And if she's in the second stage of labor, she's pushing, and then she delivers, and baby now comes out and he's like a little flaccid. The biggest job a baby has to do when they're born is to breathe. And so we kind of made him sleepy. So is he going to be rigorous at birth? No. So you have to have Narcan or on hand, and write that down. This is Narcan right here. And you have to have that and is used to reverse respiratory efforts. So I always have Narcan available. Okay. All right. That's a hint, folks. Write that term, that medication down. Naloxone. That's Narcan. All righty. All right. Another form of analgesia. Well, this is anesthesia. Is what? The epidural. The epidural has made big strides in OB. Okay, when I first started in OB back in 1980, long before you guys were even born, the epidurals, they had the big needles and they had the big syringes, and they just pushed that medication in. And what happened? Fetal heart rate went down, and mom's blood pressure went down. Oh, what a mess. Okay, we always had to have her on her side. We had IV fluids going, and eventually that bolus of Marcaine would wear off and the fetal heart rate would come back to normal, which was a good thing. All right, so we don't want, okay, the biggest problem you have with epidural is you have hypotension of mom. Write that down. Mom's blood pressure decreases. Okay. So when mom's blood pressure decreases, fetal heart rate will decrease. In order to avoid that, we, to this day, still give boluses of IV fluids. We give a bolus. So it's all according to anesthesia. So the nurse is going to call anesthesia and say, okay, Mrs. Jones in labor room number 2, and she's 5 centimeters and asking for an epidural. Okay, nurse, what's her blood pressure? Our blood pressure's been like 110 over 70, sir. Okay. He says, go ahead and hydrate with 1,000 mLs of lactating ringers. So I'm going to give her the bolus in order to increase the blood pressure, the volume in the body, the blood volume in the body, so that when we give her the epidural, she doesn't bottom down. Make sense? So that's what you're doing. So we go ahead and get that done. And because we're giving a lot of fluids, her bladder is getting full. So once she gets the epidural in and we get her in position and her back, her back is all taped up and the catheter now is only in place, then we're able to put a Foley catheter in. So we can make sure that what we put in, we make sure it comes out. Okay. So here you can see the spinal needle. You see the patient sitting up, and she's usually in a position where her shoulders are down and she's in like a mad kitty cat position. Okay. And you ever see a cat when they get mad, they get all like, yo, and the back part, her back here, the lower back will be more pushed out to the anesthesiologist so he can feel where he needs to go. He'll anesthetize it first with some lidocaine, and then he'll insert the long spinal needle. And the main thing is during an epidural is keep the patient still. Because if you don't keep the patient still, then you can create a wet tap. And once a wet tap is there, that means a little bit of spinal fluid is leaking out. That can cause her to have a terrible headache after delivery, terrible headache. So it's best to keep the patient still. Anesthesia will work with you and say, you tell the anesthesiologist she's having a contraction. He'll stop. And then as soon as that contraction lets up, it's coming down the decrepitment, he'll begin. And then he gets that in so that he can thread, what we call threading the catheter into the epidural space. And then the needle comes out. No more needle. You only have a catheter with the tubing in, and that has to be taped to her back. And then you have the tubing that goes to the syringe, and that's on a pump. And anesthesia will take care of that pump. Okay, so again, and after she gets the epidural in, you're monitoring her blood pressure. We got to make sure the blood pressure stays within norm and it doesn't go down real low. And so if you did the bolus and everything, it should be fine. Okay, and then whenever you move a patient that has an epidural, you don't drag her back. She has to what? Pick up her back. You have to it's big turning. So usually it takes a couple nurses, because what an epidural does, it anesthetizes, puts the bottom of her body, like below her belly button, to sleep. Okay, she doesn't feel anymore. She won't feel those contractions. Remember those contractions that have the decrepitment and it goes up to the peak and comes down to the decrepitment? Well, guess what, guys? She don't feel them anymore. Is she happy? Oh yeah, it's a nice way to labor. Okay, so here's your epidural assessment. So very important, like I said before, monitor blood pressure and give a bolus, 1,000 ml bolus. And we're going to think safety. Now let me go over this. I want you to hear this. A risk of safety, because she doesn't have any more sensation in the lower half of her body, they can never get out of bed. She can't feel anything. She can't feel anything below her. So she can't, like, her legs, she can't get up out of bed and think she's going to be okay. No, boom. They need a Foley catheter. You got to keep the bladder empty. And another reason why I keep the bladder empty is so that the head, she's in labor. I want the head to descend. So if I keep the bladder empty, the head will descend even better. Okay. So because remember, that bladder is underneath that uterus and the baby's coming around and he's making those internal rotations. If the bladder is flat, he can have plenty of room to come down. Makes sense. All right. So always think safety, and there's always a risk for fall. Okay. All right. Now, another one we use is a spinal block. All right. Now, those things are good for like elective C-sections. It's much quicker. is used except for C-sections, and all movement sensation is below loss. It has a good block. Now, say she had an epidural in. Oh no, I don't want to confuse you. So we'll keep on spinal block here. So all movement and sensation is lost below actually below the block, which is pretty high for a C-section. It's right below the breast, and she can't feel anything. Okay, and we want to make sure that it's quick. They put the needle in, and then as soon as that needle goes in, he shoots the medication in, and then we lay the patient down. Usually it's given right in the operating room. Now, again, remember I went over that headache with you? It's called a post-spinal headache. And the only way for that headache to go away is a blood patch. Now, let me tell you what a blood patch is. Okay, so going back to this picture, I'm going to go back to this picture to kind of use that to help. Okay, so we got the spinal needle in, and we're getting and he's doing a spinal. So the patient moved a little bit. All right, you had a little leakage of fluid, spinal fluid. And so what happens? Sorry about that. So what happens is that little leakage of spinal fluid causes a headache. And the only way that we're going to get rid of that headache, because I'm going to tell you, let me just close my door here. The only way is to get a blood patch, because it's a terrible, terrible headache. I've had patients that, well, they went home from the hospital and they came back through the ER and they were holding their head like this. And they had sunglasses on, they had a hat on because light just kills them. And so we went ahead and got an IV in, and then we call anesthesia. So the anesthesiologist who puts in the spinal is usually the anesthesiologist that has to correct it, because he knows where he went. Okay, so this is how it does. All right, so you got the patient sitting up. You see me sitting up, and we get her into a mad kitty cat position, and he feels her back. Okay. And now he takes a 10 cc syringe, and the nurse will draw the blood from the antecubital space. And this is all cleansed with betadine. It's really cleansed with a lot of betadine, and it's a sterile procedure. So you have a sterile needle and you have a sterile syringe, and it goes in, and they will draw 10 mL of her blood. Okay, now I take that, I got sterile gloves on, I give that to the anesthesiologist. I don't touch anything, I just hands him the syringe, he takes it, and then he pushes the 10 mL of blood into that needle. Okay, boom, it seals it up. It seals up that little space that was leaking, seals it up, it causes a clot. And as soon as it does that, the headache is gone. I had patients that would hug me forever because they thought, oh my gosh, this is a miracle. Well, it's a good miracle. I'll take it. I'll take the hug. But anyway, that's a blood patch, and it works beautiful, beautiful. Okay, and then another one is called a pudendal block, and this is important to know too, because you'll see this again. So here it is. Here's your pudendal nerve. See here? Okay, it lies right here. So what we're doing is you got this. It's a very skinny needle, looks something like a spinal needle, and it's hooked onto a syringe. And then here you got your medication. And what he does, he goes inside the vagina there, and he finds a pudendal nerve. You can feel it, and he puts the block right there. Okay, nice. It's lidocaine. It's going to anesthetize it, just like when you go to the dentist and he numbs your mouth up, same thing. And this is used for like when she's going to have an episiotomy. You don't want her to feel that pain of the cutting, which is a surgical cut in the perineum. So you're going to anesthetize by using a pudendal block. Again, it's used for vaginal births. And I said episiotomy. Okay. And it doesn't relieve contractions. No, it has nothing to do with contractions. We're not doing anything to the uterus, but it does block the nerve here. And it works perfectly for episiotomy. Okay, everybody got that? That's a pudendal block. All right, we're moving right along. We're going to talk about the amniotic fluid. Please may see this again. So amniotic fluid, the color is clear. It doesn't have any odor. Now, it might have some green in it. If you see, if your patient has spontaneous retromembranes and you see like yellow or green, that means the baby had his first bowel movement in utero. That's called meconium stained fluid. Now, it's never good, but we can label her with meconium. And we're going to have her on the monitor. And we're going to keep an eye on baby and make sure that his fetal heart rate stays normal. All right. If it's really, really, really thick meconium, we can actually do an amnio infusion where we take a bottle of sterile normal saline, we hook it to an IUPC, which is an intrauterine pressure catheter, which goes right inside the uterus, and we can put fluid in there. And what we're doing is we're diluting the meconium, okay? Because meconium is never good. So we can dilute it a little bit, be better for the baby. If the fluid is yellow, now write this down. Ms. Nichols, are you writing it down? Yellow stained fluid means an infection. Yellow fluid is never good, it's an infection. And I tell you, if the amniotic fluid has an odor to it, that means there's an infection. Okay, now you might see that again. Time. What time did your water break, Mrs. Jones? I want to know what time, because you have 24 hours to delivery. Okay, when you go past 24 hours from the time that the bag of water broke, you're getting to an area of infection. So I have 24 hours to get Mrs. Jones delivered. So if she broke her bag of water today at 3 o'clock, I have 24 hours to get her delivered. And you say, well, that's a good time. That's a good enough time. Yeah, but I got to put her, maybe I had to do an induction. Maybe I had to put her in labor. Maybe she didn't go into spontaneous labor on her own. It takes time. Okay, so again, how long has it been broken? The amount, I asked my patient, well, did you have a large amount or did you have a kind of moderate? Is it a little trickle come down your leg? I kind of gauge, find out. Because if she had a copious amount, which is a large amount of fluid, I got to be a little worried because maybe that head is very high. Think about it. So more water could come down because the head is high. And then if she is laboring, I could have variable decelerations because she has a decrease in amniotic fluid. See how it all works together? So I really want to know how much water. Now, she says she had a scant amount of water. Okay, it could be a little break in the bag. That means maybe the head is down low. So only a little bit of water came out, but the rest of the water is like above the, is like on the other side of the head. The head is blocking the water from coming out. Make sense? Yeah. So that's why I want to know how much of the amniotic fluid comes out. And then, of course, the odor. There's a strong foul odor. What I said before? Infection. Remember that, guys. I'm always going, when the bag of water breaks, I'm always going to my priority nursing intervention. My priority nursing intervention is to listen to the fetal heart rate for 1 full minute. 1 full minute. I've got to know if my baby's okay. I want to make sure my heart rate is between 110 to 160. Okay. On how I can test to see if she really is ruptured, because sometimes ladies say, oh, well, I think my bag of water is broken. Okay, I can test it with some nitrocine. That's only is a pH litmus paper. And so if she broke her bag of water, when you just touch the introitus a little bit with the litmus paper, it'll turn like a green, bluish green. She's broken. And then I can also do what we call an amniosure, which is another way of knowing if the bag of water is broken. It's a vaginal swab. But nitrocine paper is much easier, and everybody can do it. All right. So that's about the amniotic fluid. So Now here is my cesarean birth. Now look at this poor baby. He looks like he's mad at the world. Yeesh. Okay. Mommy was probably in labor a long time. He's had enough, and now he's being lifted out by cesarean section. He's a little mad looking. All right. So what is cesarean birth? Is the surgical delivery of the baby. Okay. So what we do an incision through the skin and then through the uterus. All right. And we give the spinal anesthesia for. And even with a spinal tube, we're going to give them a bolus of 1,000 mLs of Bottega Ringers, because we're going to what? We want to prevent hypotension. All right. And of course, when you do cesarean, you always got to have a Foley catheter. And listen up, folks. I've seen this before. You'll see it again. Is you're putting the catheter in to drain the bladder. Okay. You're putting a Foley catheter in to drain the bladder, and what else? I'm going to prevent trauma to that bladder when they're going into do surgery. Remember, the bladder laid right underneath that uterus, did it not? Okay, so when we go in and we cut the skin. Now we're going deeper and we're getting close to the uterus. There's that bladder. If it doesn't have a Foley in it, it'll be full. I can nick that bladder. And you don't want to nick a bladder, because then you have to call a urologist in to fix it when you're doing a C-section. It's never good. So always remember this. And guys, write this down. The Foley catheter is to drain the bladder and prevent trauma in the surgery. All right. This poor little guy. He doesn't look mean. He look like he's really upset. He's been through a lot. He says, wow, this was a heck of a birth, Mom. All right. Now here you are, some indications and contraindications. So some indications would be, this is why we do a cesarean. If she has an abnormal labor, that means that we couldn't get her to progress. Some patients, they're doing fine. They get to like 4 centimeters, and then all of a sudden their contractions spread out. We try to augment them with Pitocin. We still can't get them to a good labor pattern, and they have labor dystocia. So that's an abnormal labor. So that, she don't progress, we have to deliver her. Okay. Another way to deliver is a C-section. If the baby is breech or transverse, we're going to do a C-section. So write that down. Baby is breech or transverse is an indication for a cesarean section. And that, those positions are called malposition. We can never, ever deliver a transverse lie. Now, years ago, we used to do breeches, but not anymore, because we have too many lawyers. So, sorry about that. Okay, but yeah, breech is cesarean. And then you have some maternal conditions. She may be preeclamptic, and we have to get her delivered. She has herpes. Yeah, we don't want her to deliver vaginally, because we don't want the baby to be exposed to the herpesvirus. Previous surgery on the uterus. Yeah, if you have a scar on that uterus, especially if it's if you're not if you don't go into labor, if you're a bikini cut, and we can't give you Pitocin, so you have to go into spontaneous labor, and you don't go into spontaneous labor, you're going to get cesarean. Fetal compromise. If your baby has late decelerations, you're going to get C-section, because lates are lates. And placenta previa, we talked about that earlier, you're definitely going to have a C-section, because you never want that person, that placenta is laying right over that internal os. So there's no way that baby can come through there. Or we have placenta abruption, we definitely have to do a cesarean, because the placenta is coming off the endometrium. Is never good, and that's actually that's a obstetrical emergency. Okay. Contraindications really are not too many of those. We don't have to, for fetal demise, we don't have to do a cesarean. We can put them into labor, and sometimes babies are very, very premature. They don't. But if we have a preemie, a lot of times we'll do cesarean, because The preemies have really, they have soft, very soft skulls. And so we have to be very careful with that. All right. So a good question would be about, breech presentation, breech transverse. That would be an indication for a C-section. Okay. All righty. How about forceps? Now these forceps here, these are stainless steel forceps. Stainless steel. You know how hard stainless steel is, right? They don't move, they don't give. So you put these things on the baby's head, as you can see here. And what happens, they put them here, baby's right here under the symphysis pubis bone, and mommy's pushing. Well, mommy sometimes gets real tired, and so she needs some assistance. So what we do is they put forceps on the baby, and while mom pushes, the practitioner will give a little tug. Okay. Now again, they can cause some facial paralysis. And so the practitioner, whoever is doing this, has to be well trained to use these forceps. The other one we can use is called a vacuum extractor. Now, you see the vacuum here is in a circular shape, and round shape. And so they put it on the baby's head. And again, as mom pushes, they use a little bit of pressure to bring the baby out. Now, when these babies come out, they have a little circular indentation or mark left on their head, and that will go away. Mr. Nichols, you'll see this again. Okay. Okay. All right. So here's another picture of a vacuum delivery, and I remember, when the practitioner wanted to use this, and I'm the nurse there, and I'm holding the gauge. And I just hate all this assistant stuff. Anyway, he would say, okay, Irene, give me some pressure. So I said, okay. He didn't say how much. So I would do the least amount, and he went, how much pressure did you give me? Oh, well, you didn't say how much you wanted. He said, well, give me at least 9 or 10. I went, oh, okay. And then, so he assists the baby. This is how it works. Okay. So this is what can happen too. You see this poor little guy's skull? It's in a round position. And he's really got some laceration there. Poor little thing. So in order to use it, you have to have the cervix dilate, of course. Baby has to be low enough in the birth canal. Absolutely. You're not doing any kind of high assistance. No, it has to be low. Baby has to be, it has to be in head position, head, vertex presentation. Now, I know Hesse likes this kind of question. The head has to be presenting when you're going and engaged, of course. The head is low in order to put this vacuum on. All right, and again, you have your circular edema from the vacuum mark. All right. So, and then you can have complications called a cephalhematoma, which is a collection of blood under the skull. So on the side of the head, so take your hand, put on the side of your head. Okay, so this could be where a cephalhematoma could happen. Okay, good. Thank you, Patrick. Thank you. You could have a scalp laceration. You saw that picture. And you can have another problem called a caput sarcodemian. And we'll have this more when we get to newborn. But a caput sarcodemian is in the back of the head, right here. And this is the caput. And so what happens is that this part of the head gets sucked, and you can cause this abnormality. And this one here, the caput sarcodemian, crosses the suture line. It crosses those suture lines because your sutures are going up and down, right here. And so the caput sarcodemian usually is right in the occipital area, right back here. Okay. And you probably see that in newborn more. And jaundice too. Jaundice causes these babies. Yeah, the poor little guy. Does he go through a lot here? Yes, he did. And this baby, that was really kind of traumatic looking. Okay. So here's your episiotomy and lacerations. So, yeah, first degree, second degree, third degree, fourth degree. Now, the third and fourth degree are pretty invasive. I mean, look at here. You're going through all the different vaginal mucosa, the peritoneal muscles, and now you're going into the anal sphincter. That's a good cut. She better have a pudendal. Okay, remember that pudendal anesthesia? If she doesn't have an epidural, she has to please have a pudendal. And then you have a fourth degree. So the fourth degree is the vaginal mucosa, the peritoneal muscles, the anal sphincter, and it goes all the way back to the rectum. That we call this like a C-section from below. All right, because it's wide open. All right. And so the poor little thing, you know what kind of diet sheet that you got to put these patients on? High fiber diet. Write that down. You'll see that again. High fiber diet, and make sure she drinks water. I want to make sure this type of patient doesn't get constipated. That's what you can worry about. So we'll sew her up. Oh yeah. I mean, this all gets sewn up nicely. Okay. And it's going to be sore. She's going to be swollen. She's going to have what we call ecchymosis, which is bruising. She's going to be sore. So, and she's going to be very afraid to have the first bowel movement. So that's why I'm going to put her on a high fiber diet, increase fluids. All right. And what am I going to do to relieve some of that ecchymosis and that swelling? Ice pack. Ice pack, please, for the first 24 hours to reduce that edema and the ecchymosis, which is the bleed, your bruising, and actually helps reduce bleeding. 24, and I make some good ice packs up. I don't use those chemical ones. I use real ice on the real and wrap it up in a glove and give it to her and put it down there, and it works like a charm. Believe me, ice packs. Okay, you'll see that again. Hygiene. I'm gonna go over hygiene, make sure she keeps very clean. She's got to change her peri pads a lot. Use the peri bottle every time a patient urinates or has a bowel movement. We don't wipe. No. We use the peri bottle, squirt it, keep everything clean, and just take a little tissue and pat dry. And we go from the front to the back and then get rid of it. And then take another one, front to back. We don't go any other way. All right. And then we can use some Dermaplast, Epifoam, really good numbing spray. Just don't forget, this is very painful. And then you have some Tux. Tux has witch hazel in it. And that's really good, especially if you have a hemorrhoid back there. Oh yeah. Remember, she could have a 4th degree episiotomy and have hemorrhoids. Is that painful? That's real painful. Okay, she could hardly walk. And then again, you got the water, you got your fiber. I'm definitely going to give her a stool softener. Oh yeah, some Colace. And then get her up to walking, because walking will keep her from getting constipated. The peristalsis keeps that going. Okay, so don't forget, because maybe the medication that we gave her in labor will slow down all the peristalsis. So constipation is a big problem. We don't want her to have it because I don't want her to tear open the episiotomy. And that can happen. We don't want any straining because it could tear those sutures apart. When you do, when you do your assessment on the episiotomy, I have a mnemonic. It's called RETA. So put down R, E, then another E, D, and A. Put that down on a piece of paper. Are you writing it down, Patrick? R, then E, E, D, and A. Next to R, put redness. When I'm looking at her episiotomy, this is how I'm going to assess it. So I'm looking for any redness. Okay. The first E would be for edema. Does she have any swelling? The second E would be ecchymosis, and that's spelled ECCHYMOSIS. And then I had D, I have for drainage. because I have to know what's the drainage, how much does it have. I'm looking too for the odor. An odor is never good. And then A is for approximation. That means how the sutures are. So like when you have any kind of wound and you have one, say, look at here, you have one area and I have another area. So I'm going to suture this up. And so if my sutures are not well approximated, if there's like a gap, see if there's some gaps in there, then it means that the sutures are becoming loose, and that's never good. So we want to make sure that when we look at the episiotomy, that the sutures are well approximated. And you know, guys, it's in med-surg too. When you look at a wound, you know, and you have a fresh post-op, you want to see how your sutures are. You want to make sure that your sutures are well approximated. Okay, so that's your assessment of an episiotomy. All right, then we have lochia. Now, lochia, you know, is the drainage. So you have lochia, rubra, serosa, and alba. Now, rubra is like bright red, and that can last for the first couple of days. It's all according to what book you're looking at, but usually about 2 to 3 days. It's a heavy flow of blood. The main thing I want you to know about is bright red. And then you have, and sometimes they have little clots. Well, these are little, not big clots, little clots. And then after a few days, she goes into have serosa. Now, how usually a question it asks on an exam or HESI will be they'll give you the days that she's postpartum, and they want to know, they'll give you some other information, and then they want to know what type of lochia is this, and they give you the choices, rubra, serosa, and alba. That's why it's good to know like the days, and they maybe give you like day 5. Well, she's day 5. What color serosa? What color of lochia would she have? Serosa. Okay, so that's where it might come in those kind of questions. And then lochia alba is white. It's whitish and yellowish. It's got some brown in it, some old blood, but it's mostly has WBCs and it has a lot of mucus. So this is the progression of her discharge. Now, the main thing is when you discharge planning with this patient, I want her to know when she goes home, if she's having lochia serosa and she's like day 10, then all of a sudden she wakes up one morning and she sees lochia rubra, bright red bleeding. That's not good. That's an indication that she needs to come back to the hospital immediately. That's not normal, because it could be that now the uterus is trying to get rid of some stuff that's still there. So she could have what we call retained placenta fragments. Yeah. Okay. Are you all clear on the lochia? Okay, good. All right. All right, we're moving right along and we're going to baby now. It's called the Apgar. Okay, so our Apgar, this is a great mnemonic here. So write down APGAR. And the A is for appearance. How's this baby looking? What color is this baby? Well, we don't want to be pale. Is this baby pink? And we have maybe some blueness of the hands and the feet, which is called acrocyanosis. Okay, give him a 1. How about if he's pink? Here. If he's pink, that means he's pink all over. He gets a big fat 2. All right. Now, P is for pulse. I'm going to check his heart rate. If I'm born with no heart rate, that's pretty bad. He gets a big fat 0. If I'm trying, guys, but my heart rate is below 100, but I'm trying, I'm going to get at least a 1 because I got a heart rate. Yay, thank goodness. If I have a heart rate that's greater than 100, it goes boom, 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 boom. Yes, I get it too. Yeah. Now, G is for grimace. That means, is my baby responding to me? So if you have no response to stimulation, like, you know what I used to do? I used to take my finger. Here's his little foot, okay? And I used to flick my finger, you see me flicking my finger on his foot, I get a response. If I do that and there's no response, like he doesn't pull back on anything, it's a 0. Now, if I do this and he grimaces like a little bit and it gives me a weak cry, I give him a 1. He's trying. If I do this and he cries and lets me know I really don't like this nurse, that's a 2. And so these are how the baby responds. So now the next one is A. A is for activity. You know, if I have a baby, remember if it comes out, maybe mom got narcotic during transition, and then she delivered, the baby comes out, he's real flaccid, he's got nothing. He's limp. We call it like a dish rag. Gives a 0. Okay. He's got some, you know, he's got a little bit of flexion, a little bit, he gets a 1. He's trying. If he's, you know, moving around, he's active, you know how they, because they, you know, they've been enclosed so much, when they come out, there's nothing around them to hold them back. So that's why you see these babies and they just everywhere. That's a 2. That's a good baby. Okay. And the next one is respiration. If I don't have any breathing going on, it's a 0. If I have some breathing going on, I have some slow, like you can see the chest slowly. I'm trying to breathe, helping nurse. Maybe I got some more fluid down and I can't breathe so easily, so you're gonna help me. Or if I have a baby that comes out, I love these babies that have a strong cry to them, love them. And it's just music to my ears. That's a strong cry, that's a big fat 2. And the reason why we do the APGAR at 1 minute and 5 minutes, right in the labor room, is because we need to know what level of resuscitation. Dr. Virginia APGAR, she came up with this quite a few years ago, and it lets us know as nurses and RT, the doctor, what do we have to do? So if you have an APGAR like of 7 to 10, that's good. That's good prognosis. Maybe just dry me off. You know, I'm kind of wet. I just came out of a wet environment, you know, in the air conditioning blowing. I'm cold. So dry me off. If I have an APGAR from 4 to 6, I'm trying, you know, I'm really trying. So just kind of give me a little bit of stimulation. And then 0 to 3, you need to resuscitate. So that's why we do like the 1 minute, the 5 minute, 10 minute, 20 minute. Those other ones, 10 and 20, they'll be done in the nursery, in the NICU.
You got the picture present?
Because your baby is
Asking?
Hello? Somebody here? Okay.
Oh, I think it's them. It's them that made the mistake.
Oh, I hear somebody.
Yeah, me too. I got my house. I was people.
Oh, hello?
Yeah.
Hello?
That's
Yeah,
Linda.
I should have yesterday. Exam 3 is not
Let's put
here.
everybody on mute.
Hello, put yourself on mute, please.
It's okay. I was about to ask you, you tell your friend, maybe you say she likes to write, maybe she can't get.
She is not paying attention, so can you put her on mute?
I
Ask her for
can't, I can't see her.
she had a
Okay. Linda, put yourself on mute, please. Okay. Hold on just a minute. Okay, we're back. Okay. All right, let's keep going on. Okay. So again, if your baby is struggling, what we're going to do, we're going to stimulate the infant. Okay. All right. Now here's the care of the newborn. The newborn has different phases. So you have phase 1, which is like the first 30 minutes. And it's a period where, okay, the baby's born, guys. There's he's in good reactivity. He's crying, he's with mom, he's with the family. He's doing good. Okay, so that's a good time of maybe getting mom to breastfeed. And Okay, again, a good time for mom to breastfeed and, kind of pictures being taken, and things like that. Now, phase 2 is like it goes from 30 minutes to 2 hours. So this is the time that usually what I do and after my baby's born, I usually have like an hour. So I have mom with the baby and she's breastfeeding. Then baby goes to nursery. Now, before that baby leaves the labor room, she's going to be banded. So baby gets a band, 2 bands, one on the wrist and one on the ankle, plus the security band. Okay, so then baby goes to nursery with dad and the nursery nurse. Okay, now I can do mom. I can, get her cleaned up for the mother baby unit. I always make sure my patients has a full IV bag and she still has another bag to run. I mean, I get my patient all cleaned up. By that time now, mom goes to the mother baby unit and the baby now can join mom again. So it's a kind of a nice time. So phase 1 is the first 30 minutes or so of the newborn life. Okay. And then phase 2 is from 30 minutes to 2 hours. And then the third period of reactivity is now baby had a little nap during this phase 2. Okay. And that's a good time to be in the nursery where they can, listen to his bowel sounds and they can listen to his heart rate and his respirations. And, he's a little more quieter. Okay. So you can get his vital signs. Okay. And then phase 3, I'm working. Hi, mom. Hi, dad. And so he's responsive now again to external stimuli to his mom and dad. And he begins to like suck and swallow, which is a nice thing. And he can maybe breastfeed. And you want to make sure that he's not gagging at all, that you want to, if he needs to be suctioned out, you suction him out with the bubble syringe. Okay. All right. So those are different phases. It kind of works out very nice. So let's now go into the 4th stage of labor. Recovery. All right. So what do we have to worry about in this stage? Well, I got to worry about the fundus being firm. All right. So I want to do a fundal assessment every 15 minutes because if the fundus is not firm, then she will hemorrhage. Okay. And so if she's soft and boggy, she'll bleed. So I'm going to do the fundal massage. All right. I'm going to take vital signs every 15 minutes. Every 15 minutes, I'm going to assess her pain. If she didn't have an epidural, she may have pain related to all the Pitocin I'm giving to her afterwards in the 4th stage of labor. If she has an epidural, I have to worry about her bladder. Okay, I had to worry about her bladder. And remember, we went over this already. And then, of course, if she has an episiotomy, ice pack. Okay. Now, baby, I'm hearing some noises. Could you please put yourself on mute? Thank you. Okay, baby. Now, baby will be skin to skin. Guys, remember this. You'll see this again. Skin to skin. That promotes bonding. Write that down. Skin to skin promotes bonding. And we call that the golden hour. It's a wonderful time to facilitate the bonding. Now, I'm also, it facilitates breastfeeding. And the baby, they are so smart. As soon as they come out, they know they have, the sucking reflex. That's one of the important reflexes that a baby has. And they breastfeed. They can breastfeed right away, which I love because that stimulates her pituitary to produce more oxytocin. All right. And then, of course, I'm going to take vital signs on infant. And let me just give you heads up. Please know the normal vital signs of a newborn. Okay. All right. All right. We talked about already the security band, and here's a little picture of what they looks like. remember, you have to verify anytime the baby leaves the room and comes back. Okay, if a baby's band falls off, everybody gets a new band, and it has to be done with another nurse there. It has to be a witness. So again, these bands are so important for identification. So we make sure that the right baby stays with the right mom. Okay. I've had, and you have to actually tell the parents, do not remove the band. Because some parents will look at it and say, well, I don't want that on my baby, and they cut it. No, no, no. Must leave that band on. All right. We talked about full bladder already, but here's a little slide that goes over it. So I'm just going to go over it real quick. A full bladder is distended, making it difficult for the uterus to firm up. We talked about that. It causes a boggy uterus. It causes a term called uterine atony. That's A-T-O-N-Y. That's a uterus without tone. That's what that means. And so I got to empty her bladder. Remember I talked about the bladder being here and the uterus? Everybody got that picture, right? And how it pushes up and it goes over to the side. Okay. If she has a spinal anesthesia, epidural, or a pudendal, well, pudendal not so much, but usually the spinal epidural, they don't have a sensation to pee. And so you have to be very careful about their bladder getting too full. Okay. And two, put that ice pack on the perineum after delivery, and it'll get her to void too. Here's some strategies to encourage voiding. You put some warm water in that peri bottle and you squirt it, and usually gets them to pee. The cis bath is good. Another one is some peppermint oil, helps people to pee, and blowing bubbles through a straw and water cup. I usually never, I'm going to tell you, from my standpoint, when I did that with patients, it never worked, but the warm water. All right.
That's what we're gonna
Please put yourself on mute.
do that.
Well, thank you. Okay, musculoskeletal system postpartumly. You want some abdominal tightening, head tilt, pelvic tilt. Now, this is the big one. Write this down. Mr. Nichols and Patrick, write this down. It's called Kegels. Kegels can be resumed right after birth. Kegels, why we do it? It helps strengthen muscles for bowel and bladder function. Write that down. Kegels strengthen the muscles for bowel and bladder function. Now, it can be done like 5 times an hour even. Anybody can do it. So what they do is they inhale, they tighten the perineal muscles for 10 seconds, exhale and relax. That's what strengthens. It strengthens the muscles for bowel and bladder function.
I'm so young, I 21 people.
Okay, excessive bleeding. All right, so if a patient has excessive bleeding, these are the causes. So vaginal delivery, anything 500 mLs or greater for vaginal delivery is considered a hemorrhage. 500 mLs or greater. 1,000 mLs or greater is considered a hemorrhage after cesarean. Okay. So what type of delivery? Well, if you have a baby that's pretty big, it's called an LGA baby. LGA. Let me see something. Hold on, everybody. I hearing noises. I don't know. I don't see you on here.
It was about Black History Month, and it was talking about that we don't have.
Okay. There we go. We're almost finished, everybody. Okay. All right. So excessive bleeding. Okay, this is pretty important because we talked about hemorrhage. We talked about how much for a vaginal delivery, how much for cesarean. Hessie likes those questions too. So kind of write that down. A postpartum hemorrhage, let me tell you, we call it PPH, is considered obstetrical code blue. Okay. If you don't act very quickly when a patient is hemorrhaging after delivery, you can lose her very quickly. They go into shock. And the first sign your patient's going to shock would be tachycardia. Okay. And they go super quick. So I'm checking her fundus right away to see where it is. If it's soft or boggy, we're doing fundal massage. And I'm seeing clots coming out. I have to get the practitioner in there. That means they have to go up inside to see if there's any placenta fragments, because that's usually the culprit after delivery, placenta fragments. We're going to give her oxytocin or Pitocin IV. We can give her Methogen. Methogen IM. You can only give Methogen to a patient who is not hypertensive, because Methogen will speed up the heart rate. Okay. I make sure that I got a Foley catheter if I need to empty the bladder, or a straight catheter. Now she's going to have a lot of pain because I'm not only am I giving Methogen and Pitocin, strong drugs to make the uterus contract down. She may need some ketorolac or some pain medicine afterwards. So I'm having to work really fast to get a hold of this hemorrhage, because she can die really easily and very fast on you. Okay, so I'm going to, again, watch her blood pressure and her vital signs, fundal massage, and she should respond. If you do all this, she should respond. Also, sometimes they have a laceration, and it could be quite high, but a laceration is a trickle of blood. Just write that down. Laceration is a trickle, Trickle, trickle of blood. And it's like, a water faucet, how they constantly are trickling, and it's constantly collecting. And it can, if that's blood just trickling down and nobody's doing anything about it, she can hemorrhage. So again, we want to get on top of it very quickly, because I don't want my patient to go into shock. Okay, I think we're getting to the end now. So you guys are great. You're hanging in there with me. Again, this is just promoting bonding and attachment. We had talked about skin to skin is this precious time, guys, that, and it's so important to this child's psychological welfare. They have studies where it's real interesting to study. If somebody doesn't bond with their mom at birth, that they end up having trouble as a teenager and then as an adult. Okay, so that's why bonding is so important. It includes both mom and dad. And we, as nurses, we want to make sure this is happening. Some mom and dads don't do this very well. If mom wanted, say dad wanted a little boy, mom delivered a girl. I've seen where men don't even look at the babies. They don't, because it's not a boy. They wanted a boy. I mean, this does happen. I had one lady that didn't touch her baby for a couple days. So it does happen. So that's why you got to make sure that we're observing, and make sure that, they're looking at the baby and they're calling the baby by name. And, they do, it's called in-face, ENFACE, where they put the baby, they look at the baby right in the face and they can see each other. Okay, this is just about stages of attachment and what happens. And remember, we talked about the taken in phase, and that's the mother. So just things like this is the first time after delivery, for the first day, she's taken in. I mean, basically, she's focusing on the need for what? Food and fluids. And I need some sleep. She's been through a lot. She's been through a marathon. So she's really interested in herself right now. Then she goes into the taken whole phase, where now she's more interested. Now she's had maybe some sleep. Maybe she has some food. She's feeling better. So now she's taking an interest in the baby. Makes sense. Okay. And so she's also, worried about her own self needs, but now we're interested in learning how to care for herself and the baby. So now we got a more of a normal situation. And then letting go phase just means that, you know, mom and dads have worked through giving up their previous lifestyle. Well, we have a baby now. Can't have that red Corvette. Can't have that sports car. We're going to get a minivan. Okay, and then many mothers must give up their ideal of the birth experience. Some moms get very depressed if they don't have a vaginal birth. If they didn't progress and they ended up with C-section and they didn't have that vaginal birth, it does affect them quite a bit. And I always tell them right in the beginning, there's two ways to have a baby. There's a vaginal way and a C-section. And we're going to do the best way for both you and the baby, because I want to have a healthy mom and healthy baby. And that's how it works. Okay. And then here, I just want to go over the different hormones of breastfeeding. You have to know these. So write this down: prolactin and oxytocin. So prolactin makes the milk. And then oxytocin releases the milk. And that's the same oxytocin that produced by the pituitary that was very instrumental in getting that uterus to contract. So again, it is doing its work. So now it's contracting in the breast to release the milk. Okay, so that's how it works. And the milk supply is basically is based on supply and demand. So the more the baby breastfeeds, the more milk she'll make. That makes sense? More stimulation to the breast, the more milk gets produced. All right. So I want you to know this. Heads up, everybody. Colostrum. Now, colostrum is the first stage of the breast milk composition. And colostrum has all the great antibodies in it. So like I have moms that say, oh, this is no good. This is kind of thin looking, you know? And no, it's not. It has where all the antibodies are. Write that down, Mr. Nichols. Colostrum has antibodies. Patrick, colostrum has antibodies. Okay. All right. Then it goes into transitional milk, and then it goes into mature milk. So mature milk has your foremilk and your high milk. Now we got to get into this more when you study newborn, obviously. But for now, know your colostrum that has good antibodies. Okay. And here's different breastfeeding positions. And the one that's great for C-section is called a football hold. And I know you men, you know how that football is, right? Okay, you have the baby right there. And it's great for twins too. And why is it good for a C-section? Is because the baby doesn't lay across mom's tummy where she has the incision. Babies don't get near it. And that's good, because with these other ones, his little feet can hit that incision much easier. You see that? So that's why it's so good. Okay. The main thing about breastfeeding is that you want to make sure that the baby has what we call a deep latch. That means the baby, if you see him here, he's got the whole areola in his mouth. Okay. You want that to happen. This is good. See the check mark? It says that's good. Because if he doesn't, and he does this, then he's going to make mom's nipples very sore and cracked. Now, when you get sore, cracked nipples, mom can get a condition called mastitis. And that's an infection of the breast. And it is painful. So this is what we want. We want a deep latch. See how he gets that whole areola in his mouth. See, the nipple is quite down in his mouth. And he's really now doing a good suck. Now this suck helps make more milk. Okay, so here's another picture of it. All right, so we got mom's position, baby's latching, we got baby sucking, and you want to observe too that the baby is swallowing and he's not gagging. And then when you take a baby off the breast, you just don't pull him off the breast. You put your finger inside his mouth and you break the suction. Because right here, you see, he's got a deep suction. Okay, and so you've got to break that suction, and all you do, mom puts her finger in there, breaks the suction, that releases that, and then he releases what? The nipple. Okay, if you don't do that, the nipple will become so torn apart. Okay, now how do I know? This is a big question, everybody. Now, how do I know the baby is getting enough milk? Okay, moms will ask you that. You work on the postpartum floor, moms will ask you, how do I know? Well, if the baby has 6 to 8 wet diapers per day, he's getting enough. Mr. Nichols, write that down. Baby has 6 to 8 wet diapers per day, he's getting enough fluid. Now, I want to the breast will feel firm before feedings and softer afterwards. So how do I tell my patient if they're doing good breastfeeding? Is that we'll feel the breast before feedings and feel them afterwards. Before they're firm because they're full of milk, and then we'll feel them afterwards. They'll be empty, and so it should be soft. Now, that letdown reflex, it occurs like a tingling sensation. Moms do feel it, and sometimes some milk will actually drip from the breast. Now, newborn nurses at the breast for 10 to 15 minutes per breast. Okay, 10 to 15 minutes per breast, 8 to 10 times a day. That's a lot. So you got a 24-hour picture, and that baby's on her breast 10 times a day. And it takes like 10 to 15 minutes per feeding, per breast. So you have, if you do 2 breasts, that's what, at least 20 minutes, and you're doing it every 2 hours. It's a demand. It's a high demand, but it gets better. I always tell my patients it gets better, and I always promote breastfeeding, and I always tell them, if you want to get back in your skinny jeans, you breastfeed. If you want to have 500 extra calories, breastfeed. And I usually get them to breastfeed. And then, of course, I talked about before, you want to hear the swallowing of the milk going down, and make sure that he's got a good suck, because that's all part of the neurological system of the baby. He's got a good suck, and that he doesn't gag, and he swallows. Okay, those are all survival reflexes. And then, of course, if he passes stool several times a day, he's in good shape. Okay. And then here, some moms have to pump because their baby may be in the NICU. So we teach them how to pump. Just ensure they know how to put all the pump pieces together, because those things, they look a lot better today than they did in the past. They streamlined them. Teach them how to use the settings and find the right one for them. Because you put the pump right on the breast, you know, like it's like a big nipple shield, and then you have like a little pump, and you turn it on, and it pumps the breast. Boom, boom. Just like if a baby was going to suck, that's what the pump does. You want to make sure it fits good too. And then you pump for about 10 minutes every 3 hours. And I tell you what, the women have to get up during the middle of the night too. They can't, because when they get up, if they don't, they're huge and they hurt. And a breastfeeding mom can get engorged. All right, I think this is my last thing here. About engorgement, you know, like I said, breast moms can get engorged. And so if you're not breastfeeding, you can get engorged. So you know what you can do for engorgement for both these moms is nice ice packs on the breasts in between feedings. Okay. I would remember that. All right. Now, weaning. Weaning is taking the baby from the breast and now bottle feeding. Okay. Some moms have to do that because they're going back to work. So they're making that decision. So there is no what we call right time, and gradual weaning will help because it prevents engorgement. Okay. And so if you're breastfeeding like 2 to 3 times a day, and all of a sudden you stop that, you're gonna, you can't stop it suddenly, otherwise your breast will be out to here. I mean, believe me, and they will be full of milk and they will hurt. It really does hurt. So what you want to do is you want to eliminate one feeding at a time. One feeding at a time, or if you're pumping, one pump at a time. And then always remember this, you drop the favorite feeding last. So most of the time, those feedings are nighttime feedings. And nighttime feedings are very, very comforting to the newborn. So I don't want to traumatize my baby. So I'm going to eliminate that one the last. I'll do the daytime more because baby's up and around, he's got things to look at, do, move, not really needing that comfort during the day like he does at night before bedtime. Okay. And then here, now I'm going to talk about engorgement because you will see this next week, but it's painful as the milk does come in. The breasts are hard and uncomfortable, and it can be, sometimes the baby doesn't latch on like I talked about, can cause that. So you can try ice packs, you can try hand expression to get that milk to get better, to get out. Nipple trauma is never good. Cracked, red, and very sore nipples, never good. It's usually, guys, a latch on problem. I mean, we talked about that already. So what you want to do as a nurse, if you're working postpartum, mom tells you, I'm having problems with, my baby getting on and stuff. And so what are you going to do? What would you do? Well, what I do then, I tell her, well, the next time you're going to breastfeed, let me know, call me in, I'll come in and I can watch you breastfeed and let me see what's going on. Maybe it's the way you're positioning the baby, holding him. Maybe it's the way the baby is got his mouth on your nipple, on your breast. And so let me watch. And by doing that, you don't want her to stop breastfeeding because of that. But we don't want her to have red and sore nipples either. So the best thing to do would be, let me watch the next time you do it. Okay. And then, she'll get more and more encouragement. In formula feeding, you just have to be very careful of how the formula is diluted. So if mom is doing a formula, and a lot of times those concentration of powder is a lot cheaper than buying it already made up. So she has to add water to that formula. Make sure that she uses the measuring spoon that they give her exactly, because she could over dilute the mixture and the baby won't get the nourishment and all the vitamins it needs, or she could or over to give too much formula and the baby could have constipation and stomach ache because now he's got too much of the powder, not enough. So it has to have like an even equalization of moisture with the formula. Basically, I mean, she still has to prepare everything and have bottles to buy. Those are expensive. And then sometimes you have to buy the special nipples too. So, I always try to encourage breastfeeding. Okay. So, when you got a formula feeding breast care, educate them when the milk's coming in, because the milk's going to come in because they have the prolactin that makes the milk. And then you got oxytocin that lets it down. It's still there. If they're not going to breastfeed, tell them to wear a tight bra, like a sports bra. Now, years ago, I'm gonna tell you what we did. We took a big sheet and we wrapped our patients around and around and around, and then put a big old pin, made it tight. And that really suppressed the milk volume. It really did. If they're not breastfeeding, then don't express milk. Don't do that, because anytime that you express milk, your body, you're setting a signal to make more milk. Okay, so you don't want to do that. And then the milk will dry up within a week. Okay. All right. I think this is my last go around. So this is on newborn hypoglycemic. Now, diabetic moms have microsomic babies, and these big old babies, their weight can be greater than 8.8 pounds. They're big babies. They have big shoulders. Okay, and they usually have hypoglycemic. They're usually hypoglycemic. So what we're going to do is we're going to test, and we can do right here, we can the bottom of his foot, and we use, see the little pipette here, right here, and we just get a little bit of this blood in here, and we can put that in the machine. It'll tell us the glucose. Okay, never ever draw blood from the middle of the foot. You can see that you got nerves. Here are the nerves, and here's the arteries. They're going down the middle of the foot. No, we don't do that. On the side, always on the side. And sometimes these babies are hard to get blood out of. Believe me, I know. I have a little heel warmer, and that works really, really nice. Because the babies, they show some signs and symptoms, like they're real jittery, then their blood sugar is low. They have poor muscle tone. So when you're doing your APGAR, they don't have good muscle tone. You can pick that up right there. Sweating, respiratory difficulty. Yeah, you would see that also very early. A low temperature, and babies that are hypoglycemic have a poor suck. They have a very poor suck, and they have a high-pitched cry, and they're sleeping. Kind of what people go through. Isn't when your blood sugar is low, don't you get kind of jittery? Yeah. So they have jitteriness. Okay. So that's hypoglycemic. All right. Now I'm going to stop sharing now. So that is your review for exam number 2. Okay, so I want to wish you all good luck next week. Okay, and keep pushing on, keep going forward. Okay.
Thank you
Bye,
very much.
Patrick.
Bye-bye now.
It was
Thank
nice to meet
you.
you.
See you next week.
Okay. Bye, Mr. Nichols. You do good. You study.
Mr. Nicole.
He's so sweet. Bye. You come see me. Bye-bye. Bye. Okay.